This is the Motherlands Podcast. The intention of this podcast is to provide evidence-based information through honest conversations on fertility, pregnancy, birth, postpartum, and beyond by bridging together the two worlds of allopathic medicine and holistic practices to improve the reproductive health outcomes of women. I am your host, Keely Semler. Hello, welcome back to the Motherlands Podcast. Before I introduce the next guest, I wanted to let you know that I'm hosting a deep dive live session on April 21st on medical informed consent. This is a topic I'm particularly passionate about as someone that grew up in hospitals, supporting a loved one that was sick, and now being a birth doula and an educator. I think the single most important concept to understand when it comes to maintaining health and well-being is informed consent. Informed consent is the process in which a medical provider must explain why a treatment is necessary for a patient before the patient agrees to the treatment. In this live session, I'm going to address some common scenarios I see as I support pregnant clients, both within a hospital setting and outside the hospital. We will discuss medical induction in labor and birth and what questions you can ask to determine if induction is indeed medically necessary. We will also talk about the ways in which you can invite a medical provider, whether it is a doctor or a midwife, to be a collaborator as you make informed decisions that are best for your individual body. I imagine this is going to be a rich conversation for anyone interested in joining. It's going to be on Zoom, and there's a link in the show notes to register, as well as on my website. You can use the code MOTHERLANDS when you register to receive 10% off. I first encountered Nicole Morales about 7.5 years ago. She was teaching a Spinning Babies Aware practitioner course in San Diego, and I, a wary new doula, showed up to the training. Nicole's way of teaching really opened up the door for me in my understanding of how a baby's position can really influence the rhythm and flow of labor and birth. Nicole Morales is a home birth midwife and an approved Spinning Babies trainer and a certified Birthing from Within mentor. She was also an instructor for Nijoni Institute of Midwifery and is part of breechbirthsd.com, which helps breech families navigate the system as best as possible by being an online resource center. She also recently published a book entitled Restorative Midwifery, Heart Sacrifice, which is about breech and twin births. In this conversation, we talk about the importance of listening as an active practice in midwifery care. She shares that to her, birth work is nervous system work, and nervous system work is legacy work, which is part of a multi-generational nervous system. We also talk about how the medical system tries to orient itself to make things more easy and convenient for patients, and in doing so, can sometimes create more problems. The truth is, there is nothing about labor, birth, or mothering that is convenient. Some things are just hard, and some things might be less hard. Regardless of ease or convenience, birth requires patience and presence. So thank you for being here and for tuning in. I hope you enjoy this episode. And if you find it helpful or enlightening, I would be so grateful if you left a rating or wrote a review. Thank you and have a wonderful week. I'm really curious, Nicole, if you can share, how did you find your way to becoming a midwife?
I always say that it came after me. That I tried to escape and it just came after me and grabbed me. So I had my babies young, and when I was 22, I wasn't that young comparatively to some people, but I was 22 when I had my first baby, and it was a home birth. It was a really long labor, probably about 54 plus hours, a long pushing phase, and he was born actually at my midwife's house. And afterwards, it was a lot harder than I thought it would be. And afterwards, I was like, wow, that was a great experience. And that was intense. And it led me kind of on this journey where I wrote the zine. It was back then we had zines, but it was like a big zine in the sense of a lot of pages of me journaling about my experience and also starting to do research on the history of obstetrics. And for me, I guess what called out about that experience had to do with autonomy and instinctual relationship. And so that really was something that called to me. And then I had my second baby some years later and began attending friends' births. And then eventually, one of the friends' births that I attended, she dragged me to some volunteer doula group inside of a hospital. And so I started doing volunteer doula work on weekends. And then at some point went to a few more home births, and I was like, wait, why am I in the hospital? And around that same time, I was going to self-study myself to be a midwife, right? And I had like Ancient Art of Midwifery's apprentice textbook, and I'm being facetious about studying myself, self-studying, but kind of not, in the sense I was trying to find my way. It's not like today where you go online and it's all there. Like I would print out chats, afraid that they'll get lost online and I'll never see them again, right? About specific subjects. And then I went to a midwifery conference in Oaxaca, and I was really gifted to be exposed to a bunch of information that became foundational for me past like 90s home birth culture. You know, it kind of was that next layer. And then after I was gifted a Revolso and brought it back and began doing doula work and found a local midwifery school out of somebody's basement. And that ended up becoming Nijoni Institute of Midwifery, which became an accredited school. So I was the first to utilize that program to become licensed in the state of California. I'm not sure if that actually answers your question, except for it, like I kept kind of leaving it and it kept coming after me. And and birth kind of gets to you. And, it's that special ceremonial space of being with somebody as they have this huge transformative moment. And it's more than one moment, it's a whole year.
It's really amazing to hear you talk about how much the landscape of birth has changed and sort of ebbed and flowed since you first found it or had your initial experience with it with your own births. There's something that you wrote about that I wanted to just kind of pick your brain on, and that is the importance of listening as an active practice in midwifery care, and also this idea of sort of relationship-based decision making. What do you mean by that? What does that mean to you?
I think it can mean many things. We all practice different ways. That's why it's called the craft of midwifery. And maybe it's that you utilize your whole studenthood or learning, and then you get better at practicing this craft. And I think one of the things that sometimes gets forgotten, that maybe we can exoticize, or by pretending our predecessors knew it, generations before, and that's that art of deep listening. Once assumed about birth and birth work and our presence in witnessing it, because it wasn't named, that maybe it got lost. That kind of happens, when you can't measure things or write exactly, it's just part of, as you said, the landscape of birth. Each generation, they may just forget to see what's in the landscape, or know that this kind of flower is different from that kind of flower. This bird isn't the same as that bird, or, it's like there's this landscape and you no longer notice. It's just like green foliage. So I think that the active listening, the art of deep listening and being curious, I'm still apprenticing with it, just apprentice with birth and listening to the rhythms of it. And so it can teach us if we're paying attention. And I think that so many people chalk that up to simplicity. It's overly simplistic to think about birth that way. All you got to do is listen to birth. And I think that in the process, we have to learn from a bunch of different ways. And that deep listening and curiosity will take us to being able to listen for this contraction pattern's telling us something. Because the uterus is very smart. So how do we validate that contraction pattern? Or this person's moving to this position. What is that telling me about their relationship of that baby inside of them? And we might call it instinctive positions, but maybe it's just their nerve endings and their sensation. And that's where they find the comfort. How might we help? We can just listen by watching. So you asked about the act of listening, but I think that comes from, being present with all of our senses. Then we can start to track normal for pregnancy, for birth, for postpartum, the normal rhythms. And then those normal rhythms will give us hints or clues to physiological expressions. And with those hints or clues, we might just know that we're reassured to do nothing. And we also might say, hey, maybe they need to get out of the tub and pee. Or, and so we also have our other tools that we bring, whatever they are.
That's so helpful and so interesting. Something else you wrote, and I'll just quote here, you say, outcome statistics have a weak role in obstetrics. What has been proven by scientific studies is not typically seen in practice. So for listeners that are pregnant or trying to conceive, what do you mean by this? And what do you see within your practice that perhaps the research does not reflect?
I think that there's actually maybe I didn't write or tear apart the complexity of this idea that there's levels here. First of all, the first one is a storytelling level, right? Is that research is storytelling. Like evidence-based research is a story, and we are working within paradigms within the medical institution of them comparing one medicalized story to another medicalized story, and then they prove it. But even within the institution, meaning the obstetrical medical systems, the evidence itself is showing that at this point, for instance, labor induction is not evidence-based to reduce cesarean birth. We kind of knew that, but then the ARRIVE trial came, which had all its problems, and yet it got embraced because it was simplistic to teach this generation of doctors how to induce labors, especially post-COVID. And now the evidence says not to do it. That got jumped on really quickly with one study. It showed that there was a reduction of cesarean by 3%, and there were problems with that research. And yet we know that having a doula reduces cesareans by 8%. Nobody jumped on that. But that research will never, when it's just maybe starting to come into practice with like some funds, some funding, right? And we'll see how that plays out. And then you also have at the same time, like doulas being pulled into hospitals and into systems. So we'll see how that changes the efficacy of that independent witness of a doula of 8%, right? And then you still have like the fact that with labor inductions, that change of not inducing, it was really easy to jump on inducing, but then to undo the things that people learn how to do is almost harder to put into practice. And so it usually takes 10 to 20 years for some of this information to be into practice. So for midwifery, for instance, when I learned midwifery, you just don't cut the cord. Some people call it delayed cord clamping, and we just cut it when it's like ready to be cut, right? Clamp and cut and some people don't cut it, Then years and years later, people started doing research. Of course, people were like, oh my gosh, you didn't cut the cord. The baby's going to get too much blood. Now we have evidence to show that that's not the case, that babies, when they get, I think the studies now are about 1 minute of blood, of their blood from their placenta, have higher iron levels at age 3, you have better outcomes and better APGARs. They're doing research on beds that cost a lot of money at Mary Birch Hospital here in San Diego, where they can keep the baby, the preterm baby, next to the mother, so that cord can pulse. So they're finding all this different ways of how money is embedded within research is also a whole other thing, because when there's not a whole lot of money in research, whether it be pharmaceuticals or machines or technology, it changes how research is done when there's some money to be made for it. But this whole cord, back to the cord, we just kept at home birth, that cord would continue to pulse like through the years in the hospital system. Now they've got it down to the 60 to 90 seconds. And some hospitals will do it and some hospitals don't. And many people don't feel comfortable doing it with cesareans. And so people are arguing about these seconds. When the research is now there, maybe with the preterm births, and then now that you have like these beds or these things that are going to hold them that cost money, that's also there. And I'm not saying it's all money, but this proof is there, but the practice isn't accepting it. I think that Hinsey Gore says it's like 75% of obstetrics is not evidence-based. And that's within their own research. A lot of it is just practice that has been handed down. And the other part of it is that birth is so dynamic. How do you quantify something that is biodynamic and individualized?
Yeah, I guess, one thing I do as a birth worker when I work with my doula clients is when we're talking about research, I like to tell my clients, before you even read the paper, I want you to go to the very bottom where the acknowledgments are, and I want you to find out who funded that paper, because that can give you a little bit of insight about, is that paper biased? Or is there some sort of monetary motivation for the findings? Unfortunately, this isn't what people think about or know to even look for. And so it's really hard as a doula who does work in the hospital system as well as outside of the hospital system, helping people feel like they have the information to make an informed decision. It just becomes really complex.
Yeah, and there's a lot of assumptions. They're not going to think for themselves to make decisions too.
Sometimes the medical system really is banking on the fact that patients, especially pregnant people, are not well researched so that they can be able to practice out of convenience.
And I think that most people in practices have good intention, but there are the complications that it's not just about the people. It's also like the way that I see it is that partly we all cherry pick, honestly, whether we're home birth or whether we're in the hospital setting, some of the research that we do or the things that we gravitate to. And so it does make it seem like, we have it all together, but really it makes it harder for parents when they're taking responsibility to really look through this information. And then also, there's the information that you can get, whether you go to evidence-based birth or all of that research, but there's also the stuff that like what matters to you. So it's about how it applies to what your belief system is for your family. And, and there's levels of consent. It's also realizing that you're signing a consent is one type of consent that you can sign, but then also you have your own embodied consent and what's right for you, and that you can change your mind, right? It matters what applies to you in that moment. And that you can slow down and look things up or check in with your partner or use whatever ways of or methods of coming up with answering questions.
I think this ties in to your book, Restorative Midwifery, Heart Sacrifice on Twin and Breech Birth. And I found it really enlightening as a doula because it feels like breech and twin vaginal deliveries are truly a lost art, which is why I think the way that you teach specifically is so valuable, so that the knowledge isn't completely lost. Could you explain for listeners who may not fully understand why twin and breech births are heart sacrifices?
There's different ways that we've learned to survive as in midwifery. And there's different ways that people have learned to survive as doctors and institutional systems. Sometimes when we're presented with difficult situations or choices or trying to help parents, we do what seems easy. And sometimes we do what feels safe. And we do the things that feel safe because they're safe for various reasons. It could be as everybody else is doing them. It could be safe because I've done them a million times. They could feel safe because this is what I learned from my mentor. And they did them. And they did okay. And sometimes things feel unsafe. As providers working for institutions or not working for institutions, we might look for community support. Sometimes the things that feel unsafe stimulate our nervous systems into a fight, flight, freeze response or a fawn response. Oh, midwives are great with fawn responses, like trying to be nice and get what, and have their skills be validated. And then there's like a fifth one, and that's the fifth F is forget. And sometimes it's better just to forget and safer to forget skills. And that comes down to twins and breech. And that becomes your heart sacrifice, is that you're forgetting something because you're trying to survive. And sometimes it's not that we forget them. It's sometimes that we hold on to these things, like that breech is not safe, or that vaginal twins is not safe, or whatever idea that you're taught that this institution does not support vaginal breech birth or twin birth. It's not safe. And so you hold on to that because you want to protect people. And that's a belief system. And sometimes that belief system has been there out of your survival or your mentor's survival. And maybe you protect it. You protect that belief. You avoid all the breach you can. You even try not to learn about it because it's not safe to learn about it, right? Why would you do it? Even though, by the way, a quarter of breech are surprise breech, right? So eventually everybody's going to have, if they do enough births, a surprise breech. But you protect it enough, and that becomes what also needs to be sacrificed is those protections of the things that actually may just have been out of somebody else's survival, right? And you're protecting this idea so much that you begin to sacrifice different aspects of your craft and that deep listening that was once part of it. So that's kind of the idea behind that term heart sacrifice, is that, nobody wants to take unnecessary risks necessarily, but everybody might define what risks are differently.
How do you think fear plays a role in how a provider might practice, especially when it comes to informed consent or just how a provider practices? Like, I think you talked about this in your book. You did. In fact, I have a quote here that I think would be great to sandwich in. You said, "The beads on the midwifery legacy necklace that some might call the tools of our trade don't only include our external observations. They also reflect our internal awareness and observations of our own body awareness. As we kneel at the feet of the sacred nervous system in action, we too become part of the birth's nervous system field. Our inner world is showing up as part of the birth process. And how we approach birth in that sacred field becomes part of the ceremonial landscape of birthwork." So how does fear play a role as a midwife or as a provider?
Well, I honestly think that we can bring it down to the sacred nervous system, right? That's really what we're doing. Birth work is nervous system work, and nervous system work is legacy work. We are working with generational nervous systems of this baby being born, but also of the nervous system of the person birthing, and then the providers who are present. But we also have the extended nervous system of the hospital institution that the providers are also trying to appease. And the chart itself has a nervous system, but also all of the tools of the practitioners, the belts and the amni hook to break the waters. That's an extended nervous system of the provider, but it actually might be part of the institution's nervous system too, right? And we don't always think about that, but also my nervous system directly, as I know it, affects the room when I'm scared because of mirror neurons. If my anxiety levels rise, then I can imagine that the people in the room will feel that. If I'm scared, then maybe they can be affected and be scared. This is also why I don't always like grandmothers in the room all the time. I mean, sometimes some grandmothers are great in the room for births, and others it's like, wow, there is really nothing going on here to be scared about. Would you like to go get some food for everybody? And you could cry in the car. This is still early labor. But that room, the whole tension of the room with the grandmother sitting there crying, it's affected. And who you have at your birth matters. And, the nurse you get by your bedside, they matter. And this is one of the things where sometimes we compromise what we do because we want other people to be at ease with our decisions. And some might call that a fawn response to try to placate or please someone else. And sometimes this is what this person does all the time and they're good at it. And if I change that, will they still be good at that? And we have to think about the decisions we make have some complexity to it. And sometimes it's okay for people to be uncomfortable.
So how do you regulate your own nervous system doing this work?
I think the most stressful part of my work is worrying about overlap of people. Or what if I'm sick and I can't go to a birth? Navigating that is really hard for me. I was at a twins birth this week and I was at another birth this week, and I'm just coming off of those two births. So I am literally regulating my nervous system today, trying to catch up on things and do what I need to do. But in the birth space, I think that for me, and I can't speak for others because this isn't my own process, is when I walk into a birth, it regulates mine in a lot of ways. And it's almost like I downregulate. Maybe I get a little bit of a high off of the birth giver's oxytocin. So that's partly my regulation.
I don't know if I would be able to practice birth work without the oxytocin keeping me going. It's visceral, like being around that energy in birth.
Yeah, it's a memory inhibitor too. So you keep going to births because you forget how hard they are.
Yeah. Well, and apparently that is why people have more than one baby too. We conveniently forget. Otherwise,
right.
no one would have babies.
Yeah, I agree with that.
I thought it might be interesting to ask you about routine because it's an interesting word in the world of pregnancy. And as you've already shared, each person is so unique. Each pregnancy, each baby is unique. And routine can mean so many different things depending on who you ask. So what do you think of routine and how does it fit in for you in terms of prenatal and birth care?
So I have a routine, and yet it's interesting. I mean, I was like, oh, I don't have a routine, but I do, I have my flow of when we talk about certain things, but there's also a flow of what's also coming up for the person I'm working with. So I guess the key is how do we keep the dynamic aspects of us responding and listening to what's coming up for people in pregnancy? I guess routines come from places that we forget they come from. And that has to do with, the relational development of the birth giver and the baby throughout the pregnancy, and how when that baby changes and someone's life begins to change with this baby, we start seeing those, I'll call them physiological expressions, but they're really just life shifts that are happening and bonding. And this like, oh, this baby's, I think that people talk about those holistic aspects of pregnancy where it's like, oh, well, baby's part of me. And then now baby's starting to move and be separate from me. And now it's like, I've got this human inside of me who's about to be born. And, there's this whole, we can even go back for conception. But I think that those, in some ways, all of these changes and the physiological changes will guide most people in the general routines. We just forget that. But for me, my routine is most people come in and ask their questions. And they're just like, this is what's going on with me. And this is what I'm thinking about. And we answer questions. And then usually my routine would be, once we ask questions, we talk about where you've been and where you're going, where you'd like to go, what you'd like to do. What do you feel you're doing great already? And then I usually do a lot of body work in my practice. So I'll palpate the baby because that's also part of my relationship development and connection with this baby. And not just baby's position, but also its relationship. And then we'll listen to heart rate and do all of those things. And sometimes here I do blood work. So I'll take labs if necessary. But that's my prenatal routine. And it's under a midwifery model of care, which means that, or I hope I am. I mean, that's our goal, right?
So some providers' routine might involve some kind of screening or additional information needed to provide care to the patient or the client. You mentioned lab work. I'm just curious what your thoughts are around group beta strep and that particular screening.
I try not to give out my opinions to those helping for births because everybody has answers that fit for them differently. Although I give them resources, I really like a lot of what Sarah Wickham writes about having to do with GBS. But more so, I think with GBS, I contextualize where we are right now and how we came to be in this place of asking for this sample, right? And so, I mean, I don't know if you want me to go into it now, but in the late 90s.
Yeah, I think it's really interesting just to understand the historical context. And I guess that's what I was getting at more than what do you think as an individual, because just when it comes to prenatal care, my understanding is the US is one of the few Western countries that even screens for it in pregnancy. How does that happen?
How did we get here? I mean, I think this is a good question, how we got here and how it is the theme. Each decade I'll have a thing, and I have a feeling someday we're going to find out that there's different types of GBS. And then, of course, we can think about the fact that a third of our population is getting antibiotics at birth, and how is that affecting microbiomes. And we're also seeing higher maternal and mortality rates and morbidity rate. And we keep asking, why the US? And it's like, well, let's go back and see what is different. And I'm not bringing it to GBS right there, the mortality rates and the morbidity rates, but we have to realize that there's a whole set of things within the US that is different in maternity care. And so with GBS in particular, it is the United States. I mean, the UK continues to go back and do research and then to say, hey, we would have to treat a whole bunch of people to save one baby. But we also have to look at, I mean, I think it was an extraordinary number that and I don't want to quote it because I don't want to be wrong. But we have to look at what are we doing that's creating iatrogenic effects. And so this is where we start asking bigger questions of, well, what is the rise of antibiotic resistance bacteria for the outcome for babies? Because we're preventing early onset GBS. And if we're giving antibiotics, what about late onset GBS? Because that's rose with these antibiotics. But what happened in the late 90s, I think, was important because a group of parents were really upset. They had babies die, and of course, they'd be upset of GBS. And so they started to complain in the hospital systems and to doctors and just saying, hey, if only I'd given my baby antibiotics, they might have been alive. And then so they started to change policies in the late 90s. And what they did is they educated nurses about what a GBS sick baby looked like. And in educating the nurses, the numbers of babies that died went down significantly. And these are the same things that for a home birth that we would be looking for. And we wouldn't know it was baby had GBS, but we would know a baby had an infection and that they were sick. And, we'd be looking for temperature stability. We'd be looking for rapid respirations or difficulty breathing. And, so all of those different things they were educated about. And that is where the largest drop for the babies who died went down, is with that education. In 2002 is when in GBS, actually, they started with prophylaxis, with giving antibiotics for anybody who tested positive. And the numbers of babies that died went down very slightly at that point. And the numbers of babies that got sick went down. But it was really this piece of education about what a sick baby looked like and paying attention that really made the difference. And and what we also know about GBS is that it can come and go, that you can be positive and then you can be negative, and you could be negative and you could be positive. I do believe that this is a complex institutional situation because of how much is put upon the importance of testing negative or positive for GBS, rather than stepping back and looking at things that might cause that, or imbalances in the body, or maybe even because we're checking both the vagina and the rectum, that maybe it's present in the rectum and not in the vagina where the baby would be exposed. But we also have babies who are born by cesarean who get GBS too and become sick. And I don't want to also discount people who've had bad outcomes with their babies, but we're also looking at very small percentages. And so this is also one of those places where parents can make decisions about what's right for their family, right? Because the standard of care is antibiotics every 4 hours in labor. I think other countries will utilize other benchmarks for risk for infection and not just focus on GBS. I think in the UK, they check for group A strep, not group B strep, because it is much more deadly, but it's also way rare.
What are some of the imbalances within the body that can contribute towards the group beta strep? I know some, but I'm just curious what you have to say.
I'm curious about what you have to say. I was going to just talk about acidity in the vagina, right?
I was going to talk about nutrition, but I think that's interesting.
Which affects the ecological environment of the vagina, right? It's nutrition, it's immune system.
Yeah, and
sugar.
How many, medical providers or doctors are talking about nutrition? Not very many.
Yeah, there's a disparity over how food is discussed. There's a lot of opportunities of pregnancy, of changing a lifestyle that can affect someone's entire life span, possibly because it gives us little insights into 15 years in the future, right? Sometimes 1 year in the future or 5 months in the future, but you can start to see like sugar instability is telling us a little bit about later. And like, wow, if we can make these food changes now, we can really change someone's life so that they can thrive better 10 years from now, right? That's the other thing about prenatal care. It's just this beautiful opportunity for someone to take responsibility in a different way.
That's so, so profound. I'm so glad you said that. I'm jumping around a little bit, but do you think the way that a baby is born can impact how well a baby is able to feed? Like the way in which they come through the birth canal? Yeah. Can you say a little bit about that? Because I know that, supporting clients in birth, depending on how the delivery goes, if the baby's asynclitic, anything like shoulder dystocia, things like that, I have a sense that that absolutely can impact, how well a baby can feed. But I'm curious if you can speak a little bit about that.
Well, I think that one of the things I say about birth, not about feeding, but I can apply it to feeding, is one of my sayings is that it's good to look to the whole with a W rather than the whole, meaning like the cervix, right? And I think the same issues happening with latching and nursing is people are looking at the latch rather than the whole baby,
Hmm.
right? And that anatomically, we have historically, physicians have divided the structures into pieces, right? So that they're all separate. And they know they're put together because they're all inside the same body. But sometimes maybe we forget that there's a whole body that gives us more resources when we're looking at challenges. And so with nursing, one of the things that happen in pregnancy, and it's not just birth that can affect a baby's ability to nurse or its ability to turn its head. Like if they happen to a pendulous belly and the head's to the side, they could end up with torticollis, which can affect their oral motor function. Or let's say the baby gets pulled out and the neck gets wrenched from a shoulder dystocia or from a vacuum extraction, then that can affect neck. But even just hypertonicity from stress in general, we have to wonder how hypertonicity and stress affects birth, one, but how it also could affect the muscles and the connective tissues that are all connected to the releasing of the jaw and the ability for the tongue to dock on the breast. And so that sucking motion, a lot of times it releases, things release the more, like the whole, they say, oh yeah, the head molding comes back. It unmolds as the baby's, even more as the baby begins to suck, right? And they bring all of those sutures and fontanelles, like everything kind of comes back into place. But these areas that are tight, especially along fascial lines, which can come all the way up into the head and the neck, they're all connected to the jaw too. The whole body is connected with the connective tissue that seems to be discarded when we talk about anatomy. And so some of the unwinding that I believe has to happen for a baby or can be helpful to occur for some babies, that compression can change the amount of freedom of movement for their ability to latch. I think that's why a lot of people are doing body work. They're starting to look at the value of body work, whether it's craniosacral therapy, because that's gentle, or even fascia therapy that is more applied towards infants for releasing tension in the jaw.
And, how many people go to the extreme to get their baby's tongue revised or lip revised because that's just what their doctor said it needs to happen without, again, looking at the big picture of the whole, as you say.
There are times for that, but I have to say it's become quite popularized, especially actually, I think actually the popularity is towards the natural birth culture right now more than anything. And I think we're just in a period where we need to be more aware of the fact that sometimes it's just really hard to breastfeed and babies cry and have colic, and there may not be a quick fix for it. And I think we need to be mindful of the quick fixes, even for breastfeeding, in the same way. Although sometimes some things are easy or seem easy, sometimes we have other ways of looking at things.
I can't think of any part of birth or being a mother or raising children that is convenient or easy.
Yeah.
And yet that
Yeah.
seems to be the way a lot of the, medical system is going, is how do we make this the most convenient?
Well, there's no easy way out. We know that. I think these messages of ease kind of come from both polarities of directions of people imagining ease even in home birth settings, that I don't need to prepare for anything. And then they're like, wow, this is harder than I thought it would be. And sometimes it's easier than they think it'll be, but maybe nursing's harder than they thought. That we all don't escape with ease with everything, right? But there's also the fact that us doing this work, there's this beautiful opportunity in it. Even though it can be such difficult work, there's like a joy of taking responsibility in doing it. And it's also just really hard, deep work.
Yeah, I feel that way every time I go to a birth. Even if it goes seemingly well, it's still what is required. It just takes a lot.
Yeah, that's surrender.
Yeah. Well, Nicole, thank you for your time. I'm wondering if you can share for listeners your book, and you're about to release a new book, and how might people be able to connect with you if you want to be connected with?
They can find a lot of my work. Let's see here, there's several places right now. I have a lot of books. I have books. I have the Breech Release, which you can find at thebreechrelease.com. And that is workshops for birth workers and body workers, as well as a book about navigating breech pregnancy, from everything from counseling to body work to utilizing positions to preparing for ECVs. I also have Restorative Midwifery, and you can go to restorativemidwifery.com for that. And that's coming out in 13 books as a storytelling series for birth workers. You got the special edition, so that's out already, even though that's not one of the 13. And so you can go onto everything you can buy on Amazon. But somehow you can't search restorative midwifery on Amazon. I can't find the right person to complain about that too. But it's there. You just have to Google it. You can also find me if you're interested in doing workshops at restorybirthwork@gmail.com or .com. And then I'm at Nicole Morales Midwife on Instagram, and that's probably the easiest place. I also have a midwifery practice.
In San Diego?
In San Diego. But that's okay. I'm full right now. It's kind of trying to find those rhythms of teaching and attending births. It's a new rhythm for me. So I'm trying to navigate it.
Thank you so much for sharing and your incredible wisdom and expertise in the craft of midwifery and birth work. It's so needed. And like I said, you left such an impression on me 7.5 years ago. I was just so grateful that you were willing to chat today. So thank you.
Yeah, thank you for having me. I appreciate the thoughtfulness of each of the questions, and that I actually read the book or at least pieces of it, and that you're appreciating. As a culture, the culture looks for sweet sound bites and the ease of stuff, and you chose the ones that had some of that complexity in there, some of those questions. So thank you for that. I know that's hard to navigate in a podcast.
Yeah, I'm sure everything you shared is going to really give people a lot to think about, for themselves as individuals, which is what it's all about. So thank you.
All right. Thank you.
Thank you so much for listening. If you enjoyed this episode, feel free to share with friends and family, and stay tuned for the next episode.